Welcome, everyone. I'd like to welcome you here today. Thank you all for coming. Before we get started, I just want to review our interpretation instructions. Next slide. Avant de commencer aujourd'hui, passons en revue de les instructions d'interprétation. For interpretation from English to French, click on the globe at the bottom of your screen. There you can choose if you would like English or French. Next slide. My name is Jennifer Stevens. I'm the Principal Technical Advisor at JPIGO and a member of the Postpartum Community of Practice Secretariat, and I'll be getting us started today. Feel free to introduce yourself in the chat box. Next slide. I'd like to welcome you all to our third and final webinar in the Postpartum Community of Practice 3-day webinar series. If you were here the last 2 days, you know we enjoyed the speakers who were world-renowned specialists in PAS. They discussed PAS epidemiology, pathology and prevention, and antenatal diagnosis. Today, we wrap up with management of Placenta Accreta Spectrum. Throughout the presentation today, please put any questions you may have in the Q&A box. We will be reviewing these during the Q&A session at the end of the presentation. We do have a brief disclaimer before we get started. Next. The content you're about to see includes medically appropriate but graphic images. Viewer discretion is advised. The intention is not to offend, but to provide information to health practitioners and implementers. Proceed only if you are comfortable with potentially sensitive topics. Now, I would like to welcome our facilitator for today, Kasum Tapat. Please, Kasum, take it away. If Kasum is here. I can introduce if Kasum is not here.
No, that's fine. Thank you.
Oh,
Thank you so much,
Jen.
It was just, I was not allowed.
No problem.
So good morning, good afternoon, good evening, everyone. And welcome to our day 3, as Jen mentioned, of this series of webinar. Today, we will be discussing about the management of PAS and placental retention. So as Jen just mentioned, for the last 2 days, we've been really highlighting on the epidemiology, pathogenesis, prevention, and antenatal diagnosis. One thing which really stood out in the last 2 days webinar was that PAS rates are increasing, particularly with increasing cesarean section. And John and Doris really highlighted on that. Yesterday, Sally highlighted that the single greatest risk factor is previous cesarean delivery, and that in women with 3 previous cesarean, the placenta previa incidence of PAS is about 40%. So we all are aware of this magnitude of this problem and what it means in terms of maternal mortality and morbidity. So it's very important that we really learn about the management of PAS. And today, I would like to really introduce Professor Eric Janau, who's a professor in obstetrics and fetal medicine, EGA Institute of Women's Health, University College of London in UK, and has worked for over 30 years on placental and fetal development and on the diagnosis and management of placental-related complications of pregnancy. He was the coordinator of the FIGO guidelines on the diagnosis and management of placenta accreta spectrum disorders in 2018, and also was the lead developer of the RCOG Green Top Guideline 27 on placental previa and placenta accreta. So we are very fortunate that Professor Eric has taken time out of his busy schedule to be with us today and to really discuss about this very, very important condition. Over to you, Professor.
Thank you very much for your very kind introduction, and let me share my screen. Okay, everything all right? Can you see my slides?
Yes, go ahead.
All good? Okay, well, let's start. Yes, indeed. When I was first invited by Andrew Weeks to talk about it, I thought I was going to talk about the link between postpartum hemorrhage and placenta accreta spectrum. But then it has moved to operative techniques. But if you allow me, because I think there's a lot of confusion around the epidemiology and the diagnosis, although I think that in the last couple of days you've had some updated information. But if you read the literature, you will still find a lot of relatively confusing data because it's a kind of new area of research, and so everybody's been jumping on it and not always with much experience on the topic. So there's absolutely no doubt that cesarean section creates a cesarean section defect, that a cesarean section defect will be the factor that will enable a pregnancy to implant and develop inside the scar, becoming a scar, often an ectopic pregnancy as it protrudes outside the uterus. And this is obviously, for those who are continuing, the basis of the development of placenta accreta spectrum. As you just said, and I've been saying this for many years, more than 95% of placenta accreta now, and this probably has been the case for the last decade, are linked to the increase in the number of cesarean section in high-income countries. And there is no doubt that the more scar you have, the more scar defect, the more scar pregnancies, and therefore the more placenta accreta you get. Now, they do exist, and actually the first two cases I saw in my career were not after a cesarean section. They were after perforation of the uterus of the upper segment that had not been repaired, leaving quite a large gap, and that resulted in a focal placenta accreta. But no, overall, with a high number of cesarean section, any of these conditions on the left side of my slide represent less than 10% of placenta accreta. Yeah, cesarean section is definitely the problem. We've been discussing this for years as well at the FIGO and at other international organizations. We are now close to a pandemic in some part of the world. You can see this is the latest report from the WHO published in the Lancet in 2018. We are now performing, and it's probably more today, 6.2 million unnecessary cesarean section every year. 50% of them are in China and Brazil. But China and Brazil actually are not a major problem when it comes to placenta accreta because they have a relatively low fertility rate. When you see what happens in Egypt, that now has a cesarean section rate of over 70%, where it was, less than 15% 30 years ago. They also have one of the highest fertility rates in a middle-income country. And so in their part of the world, it is really an epidemic. And this is one of the main reasons I'm collaborating with colleagues at Cairo University, because they see 2 or 3 cases every week just in one central Cairo maternity. Now, if you look at the rest of the world, the problem is more getting access to cesarean section in countries that are actually producing 90% of the births. We're not talking about placenta accreta here. We're talking about giving birth. High-income countries represent probably 8% of the births in the world. But in many of those countries in Latin America, Africa, and Asia, and Africa in particular, we have 54% countries that do not meet the safe motherhood level of cesarean section of 10%. So you may ask within this context if, compared to attracted labor and postpartum hemorrhage, which are the main cause of maternal mortality, if a placenta accreta spectrum is really something quite important. Now, going back to high-income countries, everything we do now is based on guidelines and classification, and I have been responsible for the development of these two important guidelines. But I must admit that at the time, we did not take into account what was going on in middle and in particular in low-income countries. And here is a review that we did of these guidelines recently. And of course, the guideline recommendation are limited by the local resource and infrastructure. So they are not really designed for low income countries. One of the main recommendations, and this is of course where it starts, is, and this is not only the RCOG or the FIGO, it's also the American College and the Canadian Society of Obstetrician Gynecologists, is that patients with imaging sign indicate a high probability of placenta accreta, in particular if they have a previa accreta, which is again 90% of those patients, should be delivered in a specialist center with a multidisciplinary team of surgeon, anesthesiologists, NICU, level 2 or 3, hematology support. This is, of course, relatively difficult in a way to organize in high-income countries. I can tell you in the UK, it's not been that easy. It is extremely difficult to organize outside, high-income countries, because you really need someone on standby, a PAS coordinator. You need to identify a lead obstetrician, gynecology surgeon, and then you need support from the perinatal pathology to confirm the diagnosis. And this is where we are having problems in high-income countries. In the UK and Europe now, we have a training program with a work directive that prevents you from making your trainees work more than 40 hours per week. And so they don't have the same exposure as people in other parts of the world have, and certainly not as much as we did when we were trained. Also, most of the surgery now is being done in gynecology by laparoscopy, which means that they never see any case of abdominal surgery or pelvic surgery in their training. I have trainees who have been 8 years in training because they do a subspecialty training in fetal medicine. They have never even assisted an abdominal hysterectomy. And these are the people who will have to run the labor ward when they finish their training. And of course, we have no low fertility rate compared to countries like Egypt, for example. We also don't have many cases of placenta accreta. And so we have now used gyne-oncologists. And of course, they are trained to do these complex pelvic surgery, like those used for radical hysterectomy for invasive cervical cancer, ovarian cancer. And they perform exactly the same procedure, which is very safe, of course, for the patient who have a placenta accreta, but it's totally unsustainable in terms of costs, but also having on standby a gyne-oncologist and his team of anesthesiologists for the rare case of placenta accreta spectrum, because even the most advanced center in the UK, for example, see maybe a case a month, and these are the busy center. And so, to block the oncologists for these cases is a real problem when we have huge waiting lists for patients with cancer, which are, of course, a government priority. Now, if you compare what the situation is between these two parts of the world, as I said, in high-income countries, we have a low number of cases, probably 1 in 1,000 births. They're all done by a senior surgeon because the less senior surgeons don't have the training, which means that we perpetuate the lack of training for the new generation because they have no opportunity not only to see gynecology surgery, but all these complex design sections are going to be done by the most senior surgeon of the team, and they don't have the time to train people on these complex cases. By contrast, of course, we have access to ultrasound training in maternal fetal medicine. We have equipment. Well, if you look at middle-income countries, and I've been to many African countries, in sub-Saharan African countries, I know the situation there is even completely different compared to countries like Egypt or Turkey, where there are high numbers of placenta accreta, where most of the training is done on abdominal surgery without access to laparoscopy. So the surgeons there are extremely well trained in doing general gynae surgery, but there is very limited access to imaging equipment, but also to training. So, each part of the world has its advantages and disadvantages. So what is the problem? Now you're dealing, as I said, in 90% of the case with a placenta previa in a patient with previous multiple cesarean deliveries, high risk of placenta accreta. Very often these patients bleed, they need an emergency delivery, and if the accreta area is undiagnosed, you have an extremely high perinatal morbidity and mortality if you don't know how to proceed with these cases. So what you have to expect, of course, you have multiple previous cesarean section, you have thick pelvic adhesion, you have often adhesions of the lower uterine segment, which can occupy more than 50% of the lower uterine segment. So it would be difficult to get to that part, which you need to dissect. There's a high risk of bladder damage. It will be impossible to reconstruct the lower uterine segment. And if you try to do so without having the experience, you will need to do an emergency hysterectomy associated with massive bleeding and massive transfusion. Of course, if you have a placenta previa accreta, you will have an increased vascularity around the area. So not only are you dealing with a tissue that's very fragile, but you're also dealing with a tissue that's highly vascularized. And then, as I said, you risk having massive intraoperative bleeding, requiring emergency hysterectomy, which are complicated procedure to do, even for people who do them regularly. Now, you've heard about imaging in the prenatal evaluation. I wouldn't say the diagnosis, because imaging doesn't diagnose a condition which is defined as the abnormal attachment of the placenta to the uterine wall. So what you do with ultrasound is you identify a patient with a low probability versus a patient with a high probability. But then, as you can see on this image here on the left, ultrasound gives you more information than simply the probability of placenta accreta spectrum. It also shows you the potential thinness, defect, dehiscence of the lower uterine segment. And this is the image at delivery. So this is going to be a quite difficult delivery. And if you remove the placenta, this area will probably fall apart and you will need to repair it, and there might not be enough tissue. So ultrasound will give you additional information than simply classifying the patient, which obviously is very important for the screening of the patient at high risk. But it will also give you information, including in patients that don't have a full placenta previa or no placenta previa at all, because again, for someone with limited experience, if you have nothing left of the lower uterine segment, when you deliver this baby, you will need to repair quite a large chunk. There's a high risk, the bladder might be involved. So we try to classify this complex C-section according to prenatal imaging and allowing to plan the surgical procedure accordingly. And the first level is when you have an anterior placenta previa covering the cervix with a normal looking uterine segment. It's not too thin, there's no bulging of the placenta, but obviously you're going to have pelvic adhesion. Because the placenta is there, you're going to have an increased vascularization. And this is a muscle that's been damaged multiple times. It will not contract very well. You definitely have to expect uterine atonia when you're able to remove the placenta. So bladder damage, relatively low risk if you are a trained surgeon, general surgeon. Average blood loss, you can expect 1,000 to 1,500 blood loss. So risk of PPH because of the atonia is certainly over 50%. So you have to be prepared to do other measures, as I will show later. The risk of postpartum hysterectomy is also there if you fail to eliminate the risk of postpartum hemorrhage. So let's look at the second level. Here you have an anterior low-lying or placenta previa, but still with no sign of PAS, but you have here major remodeling of the lower uterine segment. MRI is quite good at this, so we don't use MRI now antenatally to diagnose patient at risk of placenta accreta, but I think it has a role to play for the preoperative evaluation and the risk, because again, you're going to have the pelvic adhesion, so difficult dissection. you have a lower uterine segment which is vascularized, dehiscence, and a risk of uterine atonia for the same reason as the level before. Bladder damage, of course, is increased if you have major remodeling, because the bladder is going to be stuck on a very thin uterine scar. Blood loss would probably be over 1500. Risk of postpartum hemorrhage quite high, and therefore the risk of needing to do hysterectomy because everything else fails to stop the bleeding is also quite high. And then, of course, the most complex case is your anterior low-lying or placenta previa with the sign on ultrasound showing a high probability. You're going to have the pelvic adhesion again, hypervascularization, not only on the uterine, lower uterine segment, but also the whole pelvis with, dilatation of anastomosis. Bladder damage here is extremely high. Intraoperative hemorrhage, of course, is very high, and almost 80%, if not more, of the patient will require a peripartum hysterectomy, because even if you manage to remove the accreta area, it will be very difficult in this case to reconstruct the uterus, which is surrounded, of course, by these dilated vessels and extremely high risk of bleeding. So what about imaging? As I said, in high-income countries, in Europe, the US, North America, we have access to all these fancy ultrasound machines with color Doppler imaging. You don't have this in many sub-Saharan Africa countries outside the private sector. And I've seen very good machine in the private sector, but in general hospital, which is where most of the deliveries take place, especially in the clinics in rural area, I have experimented these machines, which you can find now on eBay for $1,000 or $2,000. I tried this one as well. It's a portable one. The patient hated it because they couldn't really see the fetus. The only one who can see the fetus is the operator of the machine. They're very small screen. You can connect them to a bigger screen. I've done that in Rwanda, but it has no sound, and a lot of the patients want to hear the baby's heart rate because that is really an important piece of information for them. You have more new machine which have all the facilities of color Doppler imaging. Again, they can be found on eBay, but be careful because a lot of these machines are very careful compared to this machine. But I'm not trying to support one brand or another, but you need to have a machine that works on batteries and solar power, recharging the batteries, because this kind of machine are completely dependent on a continuous electricity supply, very fragile, dust, humidity, not easy to find someone to repair them if there is a problem. Right, so let's go into the surgery and the surgical techniques. Primary hysterectomy following the birth of the fetus through an incision above the placental implantation. So that's one absolute no-no. Don't ever try to remove the placenta if you think that this is a placenta accreta, because that is going to lead to a catastrophe, not only of bleeding, but the whole uterus is going to collapse, and you won't be able to find your plane of cleavage. You won't be able to go down into the pelvic because the blood will move up faster than you're able to stop the vessels bleeding, and also faster than the anesthetist may be able to transfuse the patient. I've seen some horrible cases where the patient died at that sort of speed. So important thing, whatever fancy technique you use to try to repair the uterus, this is one of the latest one described in the literature by a colleague in Egypt. Never touch the placenta, never cut through the placenta, never try to separate the placenta. So then that takes me to conservative surgery, which is basically you deliver the fetus to, again, a hysterectomy incision above the accreta area, above the placenta, and then you try, if you can, if it's not too large, to resect the accreta area and repair the uterus. Now, I'm currently working on the new version of the RCOG guideline, which should be published at the beginning of next year. And there again, no well-controlled prospective studies comparing the different techniques. Everybody's got his favorite techniques, his favorite stitches. This is not based on evidence. So try to do the one that you think is the best for your patient. And with access of the suture material that you have. If you can, of course, preserve the uterus, it is better for the patient. But overall, the RCOG and the American College recommend a primary peripartum hysterectomy. If you don't have the expertise, the experience of repairing the uterus and doing this conservative surgery, it is the safest option for complex placenta accreta spectrum. Nevertheless, my colleague, Professor Ahmed Hussein in Cairo, who has been running now a specialist list for these patients for over a decade, has now done more than 800 cases, and he has managed to decrease the need for doing the peripartum hysterectomy from 100%. At the beginning, they were not taking any risk. Now that they have the experience of the last 5-6 years, they managed to reduce this to 50%. But then don't promise the patient the world, because these are very experienced surgeons, and even in these extremely experienced hands, they still need to do 50% hysterectomy. So, a brief details on this conservative management technique. The partial myometrial resection is possible only if you have a focal area of accreta. You can see that in this case, we might have been able to do this, but it was so low. This is the end of the normal uterine tissue. This is already scar tissue, actually, and there's almost nothing left of the lower uterine segment. So trying to remove this is difficult. But if you have this accreta area here, on the other end of the scar area, then you might be able to remove this with the corresponding uterine area. Then you have enough tissue to close the gap. Now, again, unfortunately, the data on these techniques are limited, mainly because there's a lack of diagnostic confirmation after delivery. So we don't really know if these cases were really placenta accreta. And again, you have to have the skills, because you have to do extensive dissection and be prepared for emergency hysterectomy and a massive obstetric hemorrhage. So the conclusion of the RCOG guideline of the next version is that uterine preserving surgery are preferable, but should only be attempted by expert surgeon and after appropriate patient or couple counseling regarding the risk. So don't promise them the world, because they will be more traumatized if you have told them that you will be managed to save the uterus, but in fact you couldn't. When the placenta is left in situ, which is a technique that has been used in Europe and a little bit in the US, you have to be careful, because these patients are at very high risk of infection, chronic bleeding, severe anemia. So you need to make arrangements to ensure that they have regular review weekly, very often, sometimes more than weekly. They come as emergency. The few cases I've been involved as a consultant were not a very good experience for the patient or for the team. And this is definitely not something I would propose in a limited resource environment, because this is a setup that's difficult to establish in a high income environment. So it is even more complicated. The risk of infection is likely to be responsible for a high maternal mortality when you don't have the environment to support this. So additional procedure. Stents were very popular. They are less popular now. In many cases in Europe, you have a urologist that's assisting the obstetrician doing the case, so they often don't need stents, because they know where the ureters are. Tranexamic acid, of course, an amazing progress in the management of postpartum hemorrhage, but it's never been really studied in placenta accreta, and in particular in previa accreta. There's no randomized controlled trial, no systematic review by June, but with the low costs and the very, very low risk of complications, it's definitely something I use on all the cases of placenta previa that I have coming through the door, and all the accreta, which are obviously much rarer. Regarding additional procedure, again, we use embolization in some cases, but we don't systematically put balloons or the catheter inside, the iliac or the uterine artery when we perform this complex surgery. It's only available in high-income countries. The Chinese colleagues seem to be using this all the time. This may be linked to the fact that the surgical training might be limited, but I can tell you the team in Egypt has an excellent success rate in these cases without having any access whatsoever to this interventional radiology technique. What about hemostatic suturing? Well, we're going more closely now to the placental retention and the postpartum hemorrhage due to other causes. Vascular ligation of the internal iliac artery has not been shown to be very efficient. Of course, the B-Lynch or the Heyman technique of suturing the uterus can be very useful to stop the bleeding. Balloon tamponade, this is obviously a very expensive one, which name I will not mention for obvious advertising reasons, but you can use a condom. It works extremely well and it costs less than $1 with a Foley catheter. You don't need to buy these, $1,000 balloon. But it will not work if you still have placenta inside. It may be a temporary measure, but the patient is going to continue to bleed if the placenta is anchored inside the uterine wall. Until you remove it, it will continue to bleed and be a source of infection. So this may be a temporary measure until you transfer the patient somewhere else, but definitely not going to save the day. Right, let's move briefly into partial placental retention, because there is a problem, especially now in the Western world, in the US and in many European countries, of overdiagnosing patients who have a partial placental retention as having a placenta accreta. Now, this is the UK Maternal Inquiry 2023. 8 patients were reported as having associated death with placenta previa. Only in 2 of these cases was it demonstrated that the placenta was also accreta, which highlight the importance of treating patients who've had previous multiple C-section with, in bracket, a simple placenta previa, with the same precaution as you would do if you suspect a placenta accreta spectrum. But anyway, you will have to wait until the laparotomy before you can exclude the placenta accreta. And so treat all these patients the same way, because if you don't, that's where you have a high maternal mortality in a high-income country. This is an excellent paper from Andrew Weeks, which I hope he will update, because it was published now 16 years ago. And I think that with all the new data that we have on both retained placenta and placenta accreta. But anyway, it gives you the base. There are 3 different types of retained placenta. What he called a placenta adherence, which is basically the uterus failing to contract. This is uterine atonia. This is more than 70% of the cases. Then you have the trapped placenta. So it's a detached placenta trapped behind a closed cervix. That's about 10% of the cases. And then you may have the partial focal accreta, when there is a small area of accreta preventing detachment. As I said, in my career, I mainly saw this in patients who had DNCs and perforation that were not repaired. It is usually a limited damage to the uterus. And because it's in the upper part of the uterus, it can be quite easily repaired, because you have a lot of healthy, strong, thick tissue around the accreta area, which you don't have in the lower segment. And we've had a problem because from the beginning, there's been this definition about placenta accreta that it refers to a difficult manual or piecemeal remove the placenta. I'm a practicing obstetrician. I've delivered 4,000 or 5,000 patients in my career, probably 3,000 vaginal births and 2,000, 3,000 cesarean section. I don't know the distribution exactly, but I never have had a patient who I classify as a placenta accreta because I had to piecemeal remove the placenta. This depends on the experience, your training. And then, since the year 2000, they have this sort of placenta accreta plus, which some Americans call, they have an obscure placenta accreta, where there is no evidence of placenta separation 20 or 30 minutes despite active management. We all use the uterotonic protocol. Of course, if it doesn't come out, you have to go in and remove it. By doing so, you end up generating a uterine atonia because you dilate the cervix, it bleeds, you partially detach the placenta, it bleeds. Very often the placenta is stuck there in the cervix, and then it's blocking the blood which accumulates above, which creates more uterine atonia. So you're in a sort of vicious circle, but this has nothing to do with the fact that the placenta is accreta. And that's probably the worst definition, is bleeding through the placental site in a well-contracted uterus. Yeah, we know 90% are placenta previa accreta. So, of course, the lower uterine segment is not going to contract. It's been operated on multiple times. It's full of scar tissue. There's no myometrium there to contract. Yes, it is going to bleed. But, I mean, how do you identify this at vaginal birth? That, astonished me that people can come up with that sort of definition. How do you see the placenta site at the vaginal birth? And this is a lot of the cases that are being reported in some large cohort in the US and Europe. And this is one of the papers that started the trend in the mixing placenta retention. And you see from the outcome of 310 cases, there only have 11 cases that require hysterectomy, which of course is not possible as you're dealing with a population of placenta accreta. As I said, even in Cairo, where they have a lot of experience, you end up having to do 50% hysterectomy, and as experience increases or the area is smaller, you may reduce that to a third, but you're always going to have to do hysterectomy if you have two accreta. I'm just showing this as an example. This is probably breaking the world record. This is a study from Switzerland, from Basel. They included 65,000 deliveries, and they had a prevalence of placenta accreta of 3.5%, which is almost 35 times more than the world prevalence. If you evaluate the prevalence of placenta accreta is between 1 in 800 and 1 in 1,000. 41% of these patients had never been pregnant before. So unless they all had IVF or, termination of pregnancy, which again doesn't fit with the diagnosis of primigravit or perforation of the uterus for whatever other reason, which would be very unusual in the young population. And of course, the fact that 5% of the placenta were actually previa in that series suggests that only 3% of these cases were actually cases of true placenta accreta. When you're dealing with a country which has reasonably low rate of cesarean section, around 30%, but the area of Basel actually has a low fertility rate, so almost impossible that more than 3% of these cases were actually real cases of placenta accreta. And this is a case I saw recently, who had been operated by a colleague, a senior colleague, of an elective C-section. We had it actually between 2020 and 2020. I had time during the pandemic to collect these data. We had 18 cases of partial retention after cesarean section. This is a new case. We now have another 25 cases to add to this series. She was obviously told by the obstetrician that at some point she had a placenta accreta. They tried to remove it. They failed because they increased the bleeding. They didn't use ultrasound guidance. Everybody from the anesthetist to the junior doctor told the patient that she had a placenta accreta. She was still bleeding. She was fed up. She was told to wait for it to resolve. She couldn't resume to a normal life. She couldn't breastfeed. She could look after her baby. She came, and this is a technique that is feasible anywhere in the world. This is the scan before I did the procedure. It was relatively well vascularized, which explained why she was still bleeding. Used the sponge forceps and the ultrasound guidance. These have smooth ends, so it's very easy to enter inside the uterus without any risk of perforating the uterus, which is obviously a real problem. And if you use ultrasound, you really don't need a lot of training for that. You can remove this in exactly 2 minutes. So again, this patient was definitely entering the UK statistics as being a placenta accreta, told that she had a placenta accreta. And this is all due to the fact that now you have specialized law firm that will sue you if you leave bits of placenta inside them. But if you go to court and you say, "Oh, Your Honor, I'm very sorry, but this was a placenta accreta, there's nothing I could do," this is obviously a lie. You will manage probably to get away with it, but this is not true. It's very important. This is probably the most important message. Placenta accreta is a clinical pathologic diagnosis. It's something that you diagnose during the operation. You can do if you want. Histopathology is not absolutely essential. And it is linked to the abnormal attachment of one or more placental lobules to the uterine wall at birth. So if your placenta can be fully detached, as we managed to do this in this hysterectomy specimen in theater on a fresh specimen, it should not be reported as placenta accreta, or like the previous case where I managed to remove it in 2 minutes with a sponge forceps. This is not a placenta accreta. Unfortunately, as soon as you raise a flag of placenta accreta, most of the database in the West will include this in the accreta series, which is why you see, people reporting in the US 30,000 cases of, placenta accreta using the WHO classification. But of course, most of those are not placenta accreta. And then definitely we overdiagnose, especially when it comes to placenta retention. And then you have to take with a pinch of salt some of the papers that tells you they have 90% conservative management in these cases, because these are not cases of placenta accreta. And so when you're trying to do this and you have a real placenta accreta, that's when you get in trouble. So in conclusion, overall, placenta accreta is a rare condition, even more in sub-Saharan Africa, where you have low rate of cesarean section. But the problem is obviously you need access to cesarean section, because that's one way of reducing maternal mortality. And of course, medication to help in the case of uterine atonia. The main complication, if you have a case of placenta accreta, is massive obstetric hemorrhage, postpartum hemorrhage. So you need to have access to transfusion. This is one of my visits to Tema in Ghana, where we were doing a program for the WHO on near misses. And the patient here was saved by her husband. This is a state hospital, not a fancy private clinic, who managed to find, with a friend who had an ambulance, 2 units of blood for his wife, who had a postpartum hemorrhage on the placenta previa. And so basically they managed to save his wife from bleeding excessively and having damage to the rest of her organ. So if you are not experienced in trying to reconstruct the uterus, do a cesarean hysterectomy. Remember that with some training, ultrasound imaging can identify operative risk, and my colleagues in Cairo were not trained for maternal fetal medicine type of imaging, and know, because we had sat down and looked at these images together now for the last 5 years, they are very good at identifying all the risk factors that can be associated with a complex cesarean section, that the placenta is accreta or not. Of course, we're talking here about patients who all present with a placenta previa. And then remember, placenta retention is not PAS. So I have been trying to help with education program with the NIH in the US, in Bolivia, with the FIGO in many different sub-Saharan African countries, and in Armenia, with medical aid films, by producing films that are translated in many different languages, local languages, and of course even languages that are difficult to get access to. And we have tried to continue this. Unfortunately, with the pandemic, we had to stop our program in Pointe Noire and in Kinshasa. And now we have made films that are courtesy to a patient who gave the funding, because these films are very expensive. We have now a series of films on cesarean scar ectopic pregnancy and on placenta accreta, which are all available if you click these links down YouTube, but on a special platform designed by Medical Aid Films. So I will leave you with this absolutely fundamental statement from one of the most important African men: education is the most powerful weapon which can use to change the world. Okay, so thank you very much for your attention, and I look forward to your question.
Thank you so much, Professor, for this very enlightening presentation. And now I would like to open the floor for the questions. Please feel free to raise your hands and we will make sure we unmute you. And please also type your questions in the Q&A box, which is at the lower end of your screen. So, Professor, we have a question here from one of our participants who's mentioning, what do you think is driving all these false diagnoses of placenta accreta? And yeah,
do you want me to be honest with you? I think it's partially in the Anglo-Saxon legal system, the fear of litigation. It's also the inexperience of a whole generation of obstetrician gynecologists who rush into doing a subspecialty training. No, you can do this as part of your general training into maternal fetal medicine, where they look at the fetus, they don't look at the placenta, and they don't look at the mother. They might be interested in preeclampsia and diabetes, but when it comes to, delivering patient on the labor ward, they haven't got the hours. And so they panic as soon as they have a placenta that's a bit difficult to deliver. And immediately they will press the red button and say, oh, I have a placenta accreta, help, help, help. Of course, what happens then is that in the labor ward book, you enter this as a placenta accreta, even if the more senior person comes and manages to take, the rest of the placenta out. So these are the two reasons. And also people want to publish, they want to be part of the action. So if you add 50, 60, 70% of these partial retention to your list, you end up with a series of hundreds of cases where only about 10% of these cases are really placenta accreta. It's a real problem because, when you ask me to talk about management, of course, the whole management depends on the fact that the placenta is accreta or not, on the fact that the patient has had multiple C-section before. And most of these cases of partial retention are actually linked to vaginal delivery and are not cases of placenta accreta.
There's just one question which I would really like to ask Professor Eric, is from Saruja Pandey. What she mentions is like an accidental finding of placenta accreta syndrome in remote and limited setting, limited resource setting, as part of emergency cesarean section, and that so much happens in our part of the world. What will be the rescue step for the provider? Like if it is just an accidental finding, a person with previous cesarean.
So I would recommend they do a fundal incision, deliver the baby. Like get the cord, close the hysterectomy, and wait for someone who can do hysterectomy. Or transfer the patient, because if the patient is stable and not bleeding, and it's possible to transfer the patient to a unit that has this kind of surgical team available. But I wouldn't try to do this myself if I don't have the regular expertise of doing it. It is the main cause probably of maternal mortality in this context, is people who don't have the expertise trying to do these complex cases all by themselves. If you do this in a big maternity every week, then you won't have a problem, even if it's accidental, discovery. But I'm aware of so many patients who have died because of people trying to do it without having had a training.
Thank you so much, Professor Eric. And there have been so many questions which has been put there in the Q&A box, but for the sake of time, we will follow up with these questions via email, and we will be also sending you all these presentations. So I would really like, for the sake of time, I would really like to thank Professor Eric for this great presentation. Thank all the presenters for the 3 days webinar. And of course, most important, all our participants who were so active and engaged in this process. Some key takeaway, which I feel is so important, is Professor Eric, you've highlighted the prenatal assessment. So I think that's something which we should keep in mind. And what not to do is attempting to remove the placenta, which you've very well highlighted. And I think you left us with a very important point about education and training. And I think that's where now the next generation, I think we should continue to focus on education and training and ensuring that no woman dies of this condition if we're well trained. So thank you so much. And I want to take the moment to thank all our presenters for the last 3 days and participants. And over to you, Jen, to take us through.
Thank you very much.
Thank you so much. Thank you, Kumar. I would like to say a special thank you to Kumar Thapa, our facilitator, and to Eric Janu. Thank you so much for your presentation today. Also, thank you to all of our interpreters who have been working behind the scenes. In the last 3 days, we've taken this deep dive into Placenta Accreta Spectrum, and I've learned so much, and I've really enjoyed all of these presentations. They've all been very different, and I hope all of you here today have also enjoyed them. I'd also like to take a moment to thank our speakers throughout this series. We had John Varillo and Doris Midbide on the first day, Sally Collins on our second day, and Eric Janu today. And a special thank you also to our technical working group who conceived this webinar series, Kasum Thapa and Andrew Weeks. Next. I would also like to take this moment to say that we'd like to invite you to the Postpartum Community of Practice annual meeting, which is coming up in November, the 6th and 7th. This 2-day online meeting will be focused on implementing the WHO postpartum roadmap with special speakers from around the world. Next. So what is the Postpartum Hemorrhage Community of Practice, you ask? It's a community of global providers, researchers, practitioners that are focused on sharing knowledge and learnings as we work towards a world where women never die from postpartum hemorrhage. So please join today and be part of that conversation. The presentations from the last 3 days will be shared with all registered participants. Please share them with your colleagues and encourage them to join the community of practice as well. Thank you again for all of your participation, your questions. We will be sending out an email following up on any questions that were not addressed. And have a very wonderful day. Thank you.